Merete Bertelsen, and I'm a physiotherapist working in Denmark in a polio clinic, which is owned and run by the Danish polio organization called Polio Denmark. The polio clinic is situated in Copenhagen, our beautiful capital, and you can see a nice picture from our city on the screen behind me. Denmark is practically on the other side of the world, but I'm sure that polio survivors in Denmark share many problems and issues with the polio survivors in Australia. So I thank the organizers for the possibility to come here and share our experiences in Denmark with you in Australia, and also the opportunity that we can learn something from you here in Australia. In this presentation, I will talk about physiotherapy in an interdisciplinary setting. I will talk about how we organize the interdisciplinary rehabilitation program for polio survivors, and I hope it can be an inspiration for you to take with you home. Besides our many years of experience with working with polio survivors, we base our work on the March of Dimes report and the clinical guidelines, the European clinical guidelines for polio survivors, and of course, current research. The three main patient groups in our clinic are polio patients, spinal cord injury, and multi-trauma patients. The clinic is an outpatient clinic, so the patients can come 1 or twice a week for assessment and treatment. And if they are in need of that, they can actually continue exercising in our clinic. We have a big training center and a warm water pool, and we do a lot of group exercising. Patients from other parts of the country can come and stay with us for 3 weeks, and even patients from abroad can do that. And last year, 666 patients actually went through our clinic, and 62 of them were referred to us for the first time. Well, a polio survivor can have issues in many areas of life, and often it's relevant to establish an interdisciplinary team around the patient. In our clinic, we have these professions. We have the medical doctor, we have a physiotherapist, not one, but we have actually a lot of physiotherapists. We have occupational therapists, we have social workers, we have psychologists, we have a dietitian, and authorities coming to our clinic. And of course, the most important part of the team is the polio survivor and his or her relatives. We also collaborate with the local municipality because they are the ones who grant pension or who grants technical aids or disability cards and things like that. So this is an illustration of the patient flow in our clinic. The doctor makes the first assessment and refers the patient to the interdisciplinary team. But before the patient comes to our clinic, we have sent out a questionnaire with questions about the acute polio, the stable phase, the recovery, what are the current problems, and very important, we want to make the patient reflect on what he wishes to achieve during the rehabilitation. So the next step will be a group interview with the interdisciplinary team where the relevant professions are present. So when we do this first group interview, we want to identify the resources and limitations within the ICF model. An ICF, I am sure you know, but it stands for the International Classification of Functioning, Disability and Health. On the top you can see health condition, and this is, of course, in this case, polio, but many polio patients have also other comorbidities that we need to take into account. Then we talk about body functions and structures, and the patient tells us about what are the problems with the body. Is there pain, fatigue? How are the paresis? Is there any new weakness? And all kinds of things. And then we talk about how this affects the activities in daily life. And we talk about how the patient is walking. Can he climb stairs? Can he drive a car? How does he get around? And of course, we talk about participation. And this is about, does he have a work? How is family situation? Can he do the groceries, leisure activities, and things like that? We also talk about if there are any environmental factors that affects the situation. It could be that the patient is living in a house with stairs, and the patient has now difficulty climbing the stairs, and what can we do about that? We also try to find out if there are any personal factors that influence the situation which we need to take into account. In this interview, we make a rehabilitation plan together with the patient. And in this plan, we write the names of the team members and contact persons. And we also have a description of the patient's daily life, including what limitations in the functions the patient have. And of course, we write what would the patient wish to achieve during this rehabilitation. We talk about goals. Should we make a long-term goal and a short-term goal so we know where are we heading? And then, of course, we make an action plan. And at the end of the interview, the patient gets this plan, so we're all aligned on what we're going to achieve. So after this interview, the patient goes to each relevant profession. Some patients need more professions than others, but we go to each relevant profession and have assessment and treatment according to the rehabilitation plan. And from now on, I will talk about what is taking place in the physiotherapy, because that is my field. So first of all, the physiotherapist records the patient's medical story. Of course, many things have been revealed in the first interview, but there might be some of the topics that the physiotherapist needs to know more about. And the topics are typically these: the acute and stable phase of polio, and if there is new muscle weakness, and where is the weakness right now, the fatigue and pain, when is the pain coming, and things like that. We talk about the functional limitations, assistive technology, what has the patient been using earlier in life, and what is the patient using now. We talk about the mobility, and if the patient has had any falls. As mentioned earlier today, many polio patients do actually fall, and it's so important to prevent a patient falling. We also ask about respiration and swallowing, if there are any issues concerning that. And we also ask about voiding. A Danish study showed that many polio survivors have more voiding problems than the healthy population. And if the patient have problems in this area, we refer them to specialists. The physiotherapist is also very interested in the lifestyle. Is this a very active person or is it an inactive person? So this will reflect how we will prescribe an exercise program. And we also talk about nutrition, especially if the patient is overweight or maybe underweight. And we talk about if the patient is willing to maybe achieve a weight loss. If there were any comorbidities, we might talk a little bit more about that. And of course, the activity and participation areas, as I mentioned before. So part of the polio population in Denmark are immigrants, and a lot of them are young. They have, of course, other challenges in the daily life than the elderly Danish population who live a more calm life. And some immigrants have not had any treatment in their home countries, so some of them arrive in Denmark with big contractures in the hips and knees and feet, and some of them have huge leg length discrepancies. So there are different problems with those people than with the elderly Danish population. Some of them have also psychological issues because they have had some traumatic experiences from their home countries. As the title of this conference says, life stages matters. And there are different issues in different parts of your life. And many of the young polio survivors, they make families, they become parents. And to become a parent with a disability is often more demanding. There's often need for special equipment, like a height-adjustable bed for the baby, maybe with wheels on, or a height-adjustable changing table, baby carrier, things like that. And also young people are often in work or attending an education, and there could be some, accessibility problems there, where we might be able to give an advice. If the immigrant does not speak Danish or English, we always have an interpreter to help, so the communication is working well. So if the immigrant doesn't speak Danish and have a very different cultural background, it can be difficult to navigate in the society and also in the healthcare system. So again, it's of great value that we have an interdisciplinary team around the patient. If we get the impression that the patient is maybe pushing himself too hard, or he cannot really explain when the pain comes and what relieves the pain, we use a diary of activities. On the left column, we ask the patient to write all the daily activities And at each activity, the patient must mark on the line how much pain this activity is giving or relieving, and the patient can also write how tired he is or other relevant comments. This paper gives a very good basis for a talk about energy management and also clarifies where there might be some need for technical aids. If the patient is very tired, we use a questionnaire called the Multidimensional Fatigue Inventory, which comprises 20 questions. And this result scores the fatigue into 5 different dimensions, which are general fatigue, physical fatigue, mental fatigue, reduced motivation, and reduced activity. And in this way, we can sort of find out what kind of fatigue are we talking about. And mostly it's general and physical fatigue that the polio survivor are scoring higher scores than the healthy population. So based on the interview and the rehabilitation goal, the physiotherapist considers which assessments and tests are relevant to perform with this patient. And we use checklists to make sure that we don't forget anything. We analyze the posture and gait and seating, of course. We check calipers and bandages to see if they still are working as they should. If the patient have muscle problems, we try to look at, is it weakness, fatigue, tension, contractures, and we look at the joint problems. Arthrosis, are there any overuse problems, instability, all kinds of normal physiotherapy. And if the patient have problems with respiration, we can measure the vital capacity. In our clinic, we have a little device for that. We look at the thorax. Is there any deformity? Is the thorax very stiff? This could also affect the respiration. If it is relevant, we can also do a neurological examination. And sometimes it turns out that the patient actually have some symptoms which makes us think that maybe the patient suffered from something else than polio. We also measure the body mass index. Body mass index, I think it's called, if the patient is under or overweight. So we have a measure if the patient is willing to try to lose some weight. And of course, we analyze the pain and we try to look into the reasons for the pain. We have already heard a good presentation today about pain, and I like this way of dividing the pain into 3 types, and I think it was approximately the same that Steve presented this morning. This division into 3 types was suggested by Anne Gaughan in a book called Post-Polio Syndrome. And the first type is the post-polio pain, which is pain in muscles affected by polio. It could be aching, cramping, fasciculation. And the next one is overuse pain, which is, of course, caused by overuse and could be pain in soft tissue, muscles, tendons, bursa, and ligaments. And then there's the biomechanical pain, which could be the degenerative joint disease, nerve compressions, as we heard earlier, bad posture, low back pain. And treatment of the pain, of course, depends on which type of pain it is. And relief of the load on joints and muscles is a good way to think. When you assess pain, you can do it in so many different ways, and I will just mention the most used one in our clinic. We use the visual analog scale, where the patient must mark on a 10 centimeter long line where he thinks his pain is. Or we use the numeric ranking scale, which is a scale where the patient must give a number between 0 and 10 to identify how much pain he has. But if you wish to measure how much the pain affects daily life, we use the Pain Disability Index, which have questions within 7 different areas of life. We also use a drawing, as you can see on the slide, where we can draw where the pains are, and we can write notes according to each pain. There are, of course, lots of other ways to measure pain, but as I said, these are the most used ones. So if there is a specific function the patient needs to improve, we use a test so we can measure the effect of the treatment or exercise program. And these are the most used tests in our clinic. For function, we use the timed stance test, and we use timed up and go. For respiration, we measure the vital capacity. And for muscle strength, we use the manual muscle testing. For balance, we use the Berg's balance test, the figure of 8 test, and the tandem test. For walking, we use a 6-minute walk test where the patient must walk as far as possible in 6 minutes. And if the patient cannot do that, we use a 10-meter walk test where we measure the time it takes for the patient to walk 10 meters. And if the patient is applying for a disability car or a parking sign, we use a walking distance test. If we wish to measure the patient's ability to absorb oxygen and create energy for the muscles, we do a cardiorespiratory test. And in our clinic, we use either the Ostrand's 6-minute cycling test or a Borg 15 test. And these tests are submaximal tests, which estimates the maximum rate of oxygen uptake per kilo body weight per minute. And if you want to know more about these tests, you are welcome to join me in the masterclass of physiotherapy at the day. So after we have finished our testing, we need to make a clinical reasoning. What are the reasons for the patient's limitations and problems? Does the patient have a back pain because of a bad walking pattern, or because of misalignment in the sitting position, or because of a scoliosis, or maybe a disc hernia or something? We need to reflect, what do we think is the cause? And also we ask, what is the patient's opinion about this? Does he have any experiences with previous treatment on the same problem? We can learn something about that. So we need to find out, in conjunction with the patient, what can be done. And we make a plan together with the patient. So educating the patient is an important part of the rehabilitation. During the individual treatment, you will normally talk about many aspects of living with polio as a chronic condition, but educating in a group is an excellent way of increasing the level of knowledge about polio, but also gives the polio survivor a chance to exchange experiences in life with other polio survivors. They can give each other very good advice, and it's always better to hear it from somebody in the same situation than from a therapist. We include these topics in our education program. What is polio and post-polio syndrome? We talk about the exercising principle. We talk about assistive devices. We also talk about the psychological reactions to having new weakness and not being able to do what you have been doing all life. We talk a lot about coping and energy management. And I said, exchange of experience is very important in this education program. So I like to divide the physiotherapy intervention into 3 elements: energy management, pain relief, and exercise. And energy management can be done in several ways, but the main purpose is to take the load off the patient. Maybe there's a need for some changes in the task at work or at home, or maybe the patient has to prioritize which tasks are the most important and to do them to prioritize in order to save some energy. Some patients really have to learn to take breaks during the day and maybe accept to use more assistive technology or bandages to support the body. And it's really important to find a good balance between activity and rest. And in this connection, the activity diary is a very good tool. If the patient is sitting a big part of the day or is even a wheelchair user, it's of course important that the patient is sitting in a manner that distributes the pressure in the best way. And we can measure this with a special device where the patient is sitting on a sort of blanket on top of the cushion, and then we can see which cushion is the best for this particular patient. When we go to the pain treatment, as a physiotherapist, we have so many tools in our toolbox, and we can use them depending on the pain problem. In the specific pain. Exercising, and especially water exercising, can give some pain relief in some patients. But then we also use acupuncture, laser therapy, transcutaneous nerve stimulation, massage and heat, and relaxation techniques. Energy conservation and rest can also give a pain relief. As I said, bandages and technical aids and weight loss can also be a matter. And of course, in some situations, the doctor needs to prescribe some medication or even surgery, as we heard before. For instance, on carpal tunnel syndrome, a little surgery can help this problem. So the last part in the triangle is exercise. Is it good or is it bad? So during time, there's been some discussions about that. In the 50s, they said, use it or lose it. And then in the 80s, when the post-polio syndrome came up, they said, conserve it to preserve it, especially in the United States, I think. Isn't that true, Joan? Yes. And I will say it depends on the situation. So if we look into what the European clinical guidelines say about exercise, it says that supervised muscular training is a safe and effective way to prevent further decline of muscle strength in slightly or moderately weak muscle groups, and can even reduce symptoms of muscular fatigue, muscular weakness, and pain. But precautions to avoid muscular overuse should be taken with intermittent breaks, periods of rest between series of exercises, and submaximal workload. So in most cases, it is relevant to prescribe exercising for the polio patient. There are, however, some things you should consider. Is the new weakness due to overexertion or to inactivity? If the person is a very active person, never rests and pushes himself too much, you might think that the new weakness could be caused by overexertion. So maybe this patient needs to learn how to take breaks and make some coping and energy management. On the other hand, if the patient is a couch potato who sits still for most of the day, you might expect some training potential for this patient, and you can probably push him a little more. Another issue to consider before prescribing an exercise program is whether the muscle strength is stable or unstable. So if the patient experiences a decline in strength, you need to be more cautious when you plan the exercise program. And as you probably know, the polio patients often have some rather strong muscle groups and other muscle groups are weaker. So you have to determine the exercise level for each muscle group. And Karen Willin and Gunnar Grimby from Sweden made this template to make it easier to plan the program. So if you look at the muscle status in the actual muscle group, in the left column, and in the middle column, you look at how strong is the muscle. So the combination of these two will guide you to the level of resistance in the exercise program for the muscle group. For training muscle strength, there are some basic principles for polio survivors. The resistance should be low to moderate with many repetitions, instead of high resistance and few repetition, which is normally used for strength training. The progression of the exercise program must be slow, and you should monitor the reactions. And the training should be planned with intervals, so the muscles can rest between the exercises. And you must also plan breaks in the training session. And of course, avoid excessive pain and fatigue. The principles for training cardiorespiratory fitness are these: also slow progression, and the exercise should feel somewhat hard at the Borg scale between 11 and 14. And the program should involve big muscle groups or all muscle groups. And bicycling is a good way to make cardiorespiratory exercises, but some polio patients do have weak muscles in the legs and cannot perform a real training program, so you have to find out how to involve the arms. And you can see on this picture, this is a bicycle where the patient has a weak leg, and she can help exercising by using her arms, and in this way get her pulse up. Swimming is also a very good way of exercising the cardiorespiratory fitness. The level should aim at being between 60 and 70% of the heart rate reserve, and should be between 20 and 30 minutes depending on the condition, and at least twice a week to maintain the level. But you need to be a little pragmatic about this, because we know that many polio patients cannot really perform this, so you need to look at each patient and see what is actually possible and do the best. A recent study in the Netherlands by Erik Vaughan showed that severely fatigued polio patients cannot adhere to an intensive program, so you need to adjust it according to the patient. So when the patient has started your prescribed exercise program, it's very important to evaluate how the patient reacts to the training. If the program is too hard, the patient can experience excessive fatigue and pain, and maybe fasciculations. And I recommend that you adjust the program accordingly. You can either exercise with less resistance, decrease the number of repetitions, or decrease the frequency of exercising, or exercise in a different way, and maybe should be more breaks. Maybe daily activities is actually enough exercising for this patient if none of this helps and the patient still experiences pain. Sometimes it's difficult to find the motivation to exercise, and joining a group can be more fun. And in our clinic, we have these groups for general exercising, balance training, Pilates, warm water exercising, relaxing group, cardiorespiratory groups, and special groups for Muslim women. And we also make home exercise programs for patients who cannot come and train in our facility. So after the rehabilitation period, where the patient has been consulting all the different professions, we need to evaluate the intervention, and this is approximately 3 months after the patient started. Some tests are repeated, and the results are presented at an interdisciplinary conference where the patient is present. We evaluate whether the goals have been reached and what needs to be done at this point. Should the patient continue training in our clinic or in a local setting? And we make a plan for the future together with the patient, and we often plan a checkup in 3 months. So after this, the patient is moving on in her life with new knowledge and a plan for the future training, activities, and participation in society. So thank you for your attention and participation. I'm not really sure